So we're talking about innovative surgical techniques, and on the dais is Dr. Rajendra Prasad, who is the pioneer of many innovations in surgical techniques. He's also presented and done us proud by showing different innovative surgical techniques in various international forums. We welcome him. He's going to talk about the sieving needle microcapsulotomy to prevent the Argentinian flag sign in an intumescent cataract. Dr. Rajendra Prasad.
Thank you, Dr. Fajili, for the nice introduction. And the talk which I am going to give here is the sieving needle microcapsulotomy, new technique to prevent Argentinian flag sign in intumescent white mature cataracts. We do not have any financial interests, whatever the devices are shown here. And friends, you know that these intumescent pearly white cataracts, these cataracts, the biggest problem is they have the high intralenticular pressure. The high intralenticular pressure could be either because of the hyperhydrated fluffy cortex, it could be because of the swollen and flocculent cortex or the voluminous nucleus, which we normally find with these cataract because of the swelling of the nucleus. And many times it's primarily because of the complete liquefaction or the partial liquefaction of the cortex in the capsular bag. Now these cataracts also, along with the high intralenticular pressure, they have a very thin and fragile and tense capsule. So that is another important point. And if you look at the OCT image, you can very clearly see in most of these cases hyperhydrated swollen lens. You can see these fluid pockets, multiple fluid pockets within the lens, and you can see the large voluminous nucleus, swollen nucleus. You'll have a very shallow anterior chamber most of the cases, and capsule is tense and stretched out. So this is what we find in most of these intumescent white cataract. And what happens actually, the simply puncturing, before you start the capsular access, simply puncturing the anterior capsule with either with a sharp tip hypodermic needle or with the capsulorhexis forceps to raise the flap, you tend to get this kind of capsular tear extension even before you could start the capsulorhexis in these cases. So this extension of the capsular tear we all are aware of, and you all must have come across in your clinical practice. It's called as the Argentinian flag sign, and this was first described by Daniel Perrone in year 2000. And Dr. Perrone described it to be the sequelae of raised intralenticular pressure, the only factor responsible for the propagation of the initial prick into radial capsular tear. And he later on, described the posterior to anterior compartment, because many of these cases have a partial liquefaction, so there would be a two compartment, the posterior compartment and the anterior compartment, and both the compartment have some sort of pressure. And when you open up the anterior capsule, what happens? The posterior compartment would push the nucleus forward, and the nucleus hits on the back of the capsule. That is another reason the tear which we have created on the anterior capsule with the forceps or with the needle, it opens up easily, and it opens up and it turns into a Argentinian flag sign. So this is one of the described, that is one of the commonest complications you come across in the intumescent white cataract. The incidence have been put forward almost from 3.85 to 28.3%. So it's a big incidence, because we definitely come across in many of our cases Argentinian flag sign. But important point which has to be seen is almost 7 to 24% of the cases the tear would extend into the posterior capsule. So this is the biggest problem with this extension of the anterior capsular tear. If the tear extends into the posterior capsule, then we may land up with many of these complications like vitreous loss, lens material drop, capsular support loss. So all these complications comes up later on. Several techniques have been described, because this is such a situation, such a complex situation, and we have to deal every day these intumescent cataract, and we land up with this kind of complications. So several techniques have been devised, and these techniques, starting from the two-stage capsulorhexis, mini-rhexis, phaco-capsulotomy, So many, like our Dr. Mohan Rajan, well-known figure, has described puncture axis. Then there is a Brazilian technique, femtosecond laser-assisted capsulotomy. It means the complexity of this situation is so it's still going on. Some sort of technique has to be developed for this situation to deal with. You all have been knowing this one-stage spiral capsular axis we started with in the beginning, but actually what happens, all these techniques, whether you call it one-stage spiral rhexis, two-stage spiral rhexis, mini rhexis, so they work well if the capsular intralenticular pressure is within the optimum range of extension. And if the capsular intralenticular pressure is on the higher range of the extension, then these techniques would not work, because the moment you put a puncture on the anterior capsule, the moment you start tearing the capsule would extend to the periphery even before you start the capsular axis. Including the small needle aspiration technique. You all are aware of this technique because this is one of the well popularized technique, small needle aspiration, where what we do, it involves pricking the anterior capsule with a sharp 26 gauge or 27 gauge hypodermic needle, and then followed by aspiration of the fluid from the intralenticular pressure. Now this technique also works when the pressure is within the optimum range, not beyond the threshold range. And we have seen in many of our cases, even before we could aspirate the fluid from the intralenticular pressure, the tear starts extending to the periphery. Even with this technique also, in many of these cases we have come across. So we had a presupposition in the mechanics of the Argentinian flag sign that the radial extension of the anterior capsular tear takes place even before attempting to decompress the bag, either while pricking the capsule or while creating a linear cut to raise the capsule. And it means there had to be some other factors responsible which assist the raised intralenticular pressure to propagate the spreading of the capsular tear, resulting into Argentinian flag sign. So it's not only the intralenticular pressure, there has to be some other factor, definitely. So we came out with this article, and we did an extensive study on the patients where the patients had the Argentinian flag sign. We reviewed these videos and we went through all the videos and seen that in reality it's not the raised intralenticular pressure the only factor responsible for the extension of the tear. It is the configuration of the initial puncture which is created to open up the anterior capsule by a sharp tip hypodermic needle or the rhexis forceps. Like when we actually start the capsular rhexis with the forceps, we first tear the capsule and then hold the flap and then start. But what happens if the pressure is beyond the optimum threshold? The moment you tear or moment you try to lift the flap, the rhexis tear starts extending to the periphery and results into the Argentinian flag sign. Similarly with the hypodermic needle also. So why it happens? You can see this small video that when you are puncturing the capsule with a hypodermic needle, you see the hypodermic needle will create a linear tear on the anterior capsule. So this is a linear tear. Now this linear tear has two open edges on both the sides. Now it's not like a hole or something, it's a linear tear. And if you have a high pressure within the capsular bag, now this linear tear would easily open up, because now there is a tear already, and the high pressure will open up this tear to the periphery, and this tear would extend to the periphery in the form of Argentinian flag sign. You can see this animation video, how this tear would extend. We have created a small tear. Now the high pressure will open up this tear into an Argentinian flag sign. Now important point which we noted, another important point which we noted, which was not known earlier, was that the tear always extends radially along the discontinuous open edges of the cut, never perpendicular. So this is very important point, because tear always extends radial to along the open edges, never perpendicular. It means this tear has to do something in the creation of the Argentinian flag sign. So we had an hypothesis that an opening with the round and regular configuration, instead of making this linear cut, is it possible to make a round and regular opening in the anterior capsule before we start the capsular axis? So because if you have a round and regular opening, the round and regular opening would have a much better resistance against any kind of high pressure or any kind of resistance which is created by the high interlenticular pressure. So what we did, we actually created a device which is called as a saving needle microcapsulotome. This device has a tip like a saving needle. It's a round and pointed tip. Now, unlike the sharp and knife-like tip of the hypodermic needle. Now when this device pricks the anterior capsule, it will make a hole on the anterior capsule. Now you can see this device. This is a round and pointed tip. Now this round and pointed tip, when prick the anterior capsule, I am showing here on the paper, this will make a round hole on the anterior capsule. Now if you prick with this device, you will have a linear cut. So there is a difference because this made a hole and this made a cut. The cut has a much lower resistance against the high pressure and the hole will have a much higher resistance. Now this hole works like a mini capsular axis of what we have been practicing earlier. We do a mini capsular axis, then we decompress the back. So this is a micro capsular axis, And this micro capsular axis also helps in the evacuation of the fluid from the interlenticular space along with creating a resistance against the initial eruption of the fluid or initial volcanic eruption of the fluid which takes place when you prick the anterior capsule in a high interlenticular pressure, especially these intumescent white cataract. So you can see here, because this is the animation, we pricked it, the fluid start coming out, and once the fluid comes out, the capsular bag will decompress completely, and then we can very easily start the capsular axis from this point. Once the capsular bag is decompressed. You can see here in this video, I'm trying to prick it with a simple needle, saving needle. Even you don't need many times this device, you can just use the simple needle also at home. We have this saving needle. You just prick it, it will create a hole in the anterior capsule and you can see the evacuation of the fluid which comes out from the capsular bag. And this pricking can be done, many times the single prick would work. But many times you know that these intumescent cataract would have a multiple fluid pockets in the capsular bag if the complete liquefaction has not taken place. Then in these cases you need to do multiple puncture to evacuate complete evacuation of the fluid. But important point is these multiple puncture has to be within the 5 millimeter zone. It should not go beyond 5 millimeter. It has to be within 5 millimeter only. Because when you do the capsular axis of 5.5 millimeter, all these holes should come within the capsular axis. And this is the video you can see here. Just last 1 or 2 slides only. This is always stain the anterior capsule. Always pressurize the anterior chamber with the good viscoelastic. And this device has to be kept vertically. It has to puncture vertically. It should have a sharp tip. So that is very important. A needle which has a sharp tip. Don't use the blunt tip. If you hit it, the anterior capsule with the blunt tip, then the capsule will disrupt. Instead of having the puncture, you will have a disruption. So it has to be sharp pointed tip, then only it will work. And then once the puncture is made, with the help of the air cannula, you can evacuate the fluid out of the capsular bag. As I'm doing here, the tearing the capsule now from that point, from that hole, and then you raise the flap and complete the capsular axis, and you do not have to worry because the capsular bag is now fully decompressed, the pressure is very low, you do not have to worry for the extension at all, and you can complete the capsular axis of size what you wish to do in your situation. So to conclude, in intumescent white cataract, it is primarily the linear cut configuration of the initial prick which has the potential to spontaneously extend along its open edges, leading to Argentinian flag sign. Saving needle microcapsulotomy with a round regular configuration like a capsulotomy in true sense. So that is the true sense capsulotomy provides resistance against the disruptive forces triggered by the high interlenticular pressure. And initial decompression of the capsular bag facilitates safe and controlled creation of a capsular axis of desired size with higher level of efficiency and safety. So these are the literature you can go through, and thank you very much. So any question, any query you can ask me, and I'd love to answer.